Bradford Health, the leader in affordable alcohol and addiction treatment for over 40 years.
Now, whenever I talk about ethics, I'm under no misconceptions that I'm going to share with you some earth-shattering information that you've not heard before. We all have to do ethics trainings repeatedly as part of our continuing education as professionals, and frankly, they can get a little bit dry. And I'm sure you've all sat in the presentations where somebody just reads over the professional code, and that's the extent of the training. I try not to do that. I do make reference to it, certainly, but I also like to bring in other data. I like to bring in some statistics and some figures that go beyond just the code itself or best practices, so that we can start thinking about things a little bit differently. Now, this training, because it focuses on substance abuse treatment providers, I like to bring in components about what it is to work as a substance abuse treatment provider. Though, as we're going to see, there's a lot of principles that don't necessarily change. It's not like there are a whole new set of codes or principles that would not apply to anyone else working with any other population or any other diagnosis. But there are always things that can make things a bit more complicated when you throw drugs and alcohol into the mix. And so we're going to take that idea and we're going to talk about that as it relates to the confidentiality, competency, and the dual relationships. So let's go back to that values proposition that I asked you to think about. Whenever I fill this out, I come into very common answers, things that I hear other people saying. Like when I think about my organization, I think about things like advocacy and professionalism and being able to provide quality care. When I think about my profession as a licensed counselor, I think about respecting clients and not doing any harm to them, and providing a service and providing the service that I say that I'm going to provide to them. Now, for me personally as an individual, my values come to honesty and providing a genuine therapeutic relationship, and also for professional development and my ability to continue to expand my skills. Now, all of those different core principles, you might have had something similar, or maybe just as I had outlined them, and many of them will fall into multiple categories. Perhaps my personal value of professional development, that might be something that within your organization you see lots of emphasis on that, and that your agency or your workplace values development. There's no right or wrong answer to it. I like to do this activity because it can be a good value clarification, and it's great for supervision or any training you're doing with clinicians, because you can talk about where things fit. And it's always good to include those 6 core principles of ethical practice, and they're included here: the non-malfeasance or do no harm, the beneficence of doing the right thing or doing good, justice, which I take to be fairness and equality, fidelity, which is basically doing what you say you're going to do, faithfulness and trustworthiness in that, veracity of being honest and accurate in what we deliver, and autonomy, and that's the value and respect we give to each individual and the ability for each individual person to be self-directive in their decisions. So if you included any of those terms in the value clarification activity we did, gold star to you. A lot of times we might use different words to describe many of the same tenets. Now, those would be good to include. Now, if you for yourself included self-care, well, extra bonus points to you playing at home, because I do this activity a lot and I don't always get people saying self-care. If people do put self-care on that value matrix, they often put it under personal beliefs, and not always putting it under profession, and even more seldom putting it under their workplace or agency as a value of that organization, which makes us really question and double check exactly how the profession is operating and how we are fitting into our organizational structures, since self-care itself is an ethical obligation that all professionals must abide by. We have to do self-assessment, and we also need to be looking out for potential risks if things like burnout or compassion fatigue are affecting clients, and being able to address that with our peers. So self-care is very important. I'm not going to spend any more time on it. That can be a topic for other times. I do another self-care presentation that goes much more in depth with that. But it's always fascinating to me how it can be sidelined many times, and the value of it is minimized in our actual practices. So as I mentioned, this is a presentation that's going to talk a lot about the inclusion of treatment of substance use disorders. So the question then becomes, well, who exactly is a substance abuse treatment provider? Is that somebody who works at a residential setting or within a detox unit or an outpatient facility that specifically focuses on drugs and alcohol and the recovery from those disorders? Well, yes, but I would also venture that a substance abuse treatment provider, because of how common substance use disorders are, really includes anybody who works with people or has worked in this field long enough. I really think that everyone is a substance abuse treatment provider to some extent, when you consider that almost 8% of the population above age 18 in the United States has struggles with illicit drugs or alcohol or a combination. There is a significant overlap with co-occurring disorders for the severe mental illness and SUD, substance use disorders. So if you're out there and you happen to be in private practice, let's say, you are going to be working with patients who are struggling with drugs and alcohol. It may not be their primary presentation when they come into treatment. Many times it's not. You might have somebody who presents with marital issues, but an underlying issue of that could be the alcohol or the drug use by one or both partners. So what this tells me is that we need to emphasize the specific issues that can arise for anybody who's going to be treating patients or clients with substance use disorders. So with that in mind, let's maybe revisit some of those core principles, just 4 of them here, thinking about justice. Justice would be free of bias, free of favoritism, equal delegation of resources to our clients. And one of the things that can come up for individuals, hopefully not for helpers, but is a bias on drug of choice, DOC. And willingness to work with certain disorders versus others. People might be more willing to work with an alcoholic versus a chronic relapsing opiate or heroin user. Also then considering the social stigma in general of the population that occurs with IV drug users versus non-IV users. Now these are social stigmas, but we must always be very conscious of our own personal values and how we view drug and alcohol use and what it means for the people that we serve. Because if we are somehow presenting some level of bias or favoritism in the people that we choose to work with substance use disorders, well, we're doing a disservice. And that's not respecting the dignity of the individual. As far as I'm concerned, drugs and alcohol are all created equal. They are all a substance when ingested cause an impact. Whether that's a positive or negative impact for the individual, well, that's where the diagnosis comes in. But that's not really the way that the world tends to view substance use disorders. So we have to always be checking our own values. Autonomy becomes a great issue of within ethical decision making for the substance use provider. Take one example of ability to make choice. Now, for many, that can run into issues when it comes to our patients wanting to make decisions about moderate drinking. They want to continue to drink in a controlled setting, or they want to just cut down on their drinking in a harm reduction method, or if they are wanting to choose total abstinence. Where this can start especially being a problem is when the practitioner has values or opinions about what is going to be the best move forward. So if we have a practitioner, let's say, who they themselves are in recovery, and they found that recovery using an abstinence-based model, well, they might find that that is the best way of moving forward, and they run the risk of imposing that value on the people that they serve. And it could do more harm if that person does not want to abide by that treatment plan, and then it's almost like it's being forced upon them, and they're likely to abandon that treatment or not comply with it, which is going to create an issue within that therapeutic dynamic. So that's a very specific example, and I brought up a recovering staff member, and that's going to come up a number of times today. And I'll go ahead and tell you one of the reasons why that's imperative to think about is that helping in the substance abuse field tends to draw more recovering people into it because they want to give back, and they saw good models of helpers whenever they possibly went through treatment themselves. And so there's a real gung-ho nature for people in early recovery to get involved in the field in one form or another. And what that can eventually lead to is licenses and degrees and all of that. But what that can do is it can create that bias at times, especially as we're dealing in the world of medication-assisted treatment, where there are strong objections among some about the utilization of replacement therapies for the pros and cons that they do present for the clients that we serve. That can lead then into the idea of do no harm. Some people can impose that idea about MAT as an idea of this might actually be doing harm versus an actual evidence-based treatment. That idea can be debated much back and forth, but I follow what SAMHSA as well as other organizations' research says, and that it is an evidence-based practice in the treatment of the disorder, and it can certainly help people who are struggling with opiate and alcohol use disorders, because I know that the alternative is withholding those medications, which I know most certainly will result in harm. And you weigh both of those options against each other, and to me, it's a non-contest about what option is going to be best. It's better to provide medication knowing that it potentially could be abusable in some circumstances versus withholding it, which could result in the person's death. There's a long-standing idea that you cannot treat dead, and I believe that wholeheartedly, and I think that as long as somebody is participating in treatment, we have an opportunity to help them. That goes kind of along one of these ideas here about discharge and discontinuation of treatment services. A treatment provider must really weigh heavily the grounds for discharge. One patient should not be discharged solely due to a drug screen that is positive for a substance, or even to that extent, their continued use. Why would we punish someone who's being basically non-compliant in their treatment plan when we know that they have a substance use disorder, and by them using, they are only acting on the disorder. They are only doing what makes sense given that they have that disorder. But historically, that would mean that someone would be dismissed from treatment. Well, that in itself is going to only propel that person away from resources, and that's going to end up doing more harm than good. And the other concept here that I want to circle back to is with the practitioner burnout. Burnout levels can be felt very acutely for those who work with severe mental illness, as well as for those who work in substance abuse treatment. Now, the thing is, we're going to have a lot of parallels and overlap of those where we're dealing with the co-occurring disorders. They can be very fatiguing for staff. Relapse is very, very common, and that can lead to a lot of false ideas by the practitioner that they're not being effective or that they're not seeing change among their clients. And that can be very disheartening for a lot of people in the field, regardless of how long they've been working in that field. It does take a toll, and that's why we have to have processes in place for consultation, for supervision, and for colleague support, because it can be very draining to work in the helping profession, regardless of your setting, for the long term. Now, lastly, one of the ideas I want to talk about here is fidelity, and where this specifically can impact helpers is where we set our boundaries and we stick to them. And so there are very strong boundaries for keeping information private and confidential. Now, that applies to all helpers. We have obligations for HIPAA and for keeping information private that is disclosed to us in the therapeutic setting. Substance abuse treatment providers have even more of a requirement on them through actual federal legislation, 42 CFR Part 2, but also an understanding as a practitioner that having information about someone's substance use disorder diagnosis, treatment history, or prognosis, that has a lot of bearing on so many other aspects of their life, including things like employment and relationships within their community. We have an obligation, very, very much so. I take it very seriously to keep information private. Now, also with that, making sure that our clients are aware of when those exceptions might take place. That would be something like a reporting of child abuse or neglect, which I will speak to a little bit later on. But we inform all clients of that at the onset and throughout treatment. And when we do that, when we're very clear about those boundaries, what we do is we stick to that, and we show them dignity and respect when we uphold them in circumstances. Now, of course, the other aspect of boundaries is actual relationship boundaries, which we're going to talk about too in just a moment as we go. But first, let's go ahead and make a definition of what ethics are. Generally regarded as the standards that govern a profession, persons within the profession. So they are guidelines that help us protect not only the profession itself, but also myself as a professional, of course, the client, and also society at large. Now, because ethics are a living document, they are prone to change. They are updated from time to time. Depending on what profession you are representing today, your board, your national board, like social worker, counselor, marriage and family, depending on how old the ethical code was written, is going to be more up to date than others. Like, for example, social workers have a more up-to-date version of their ethical codes than counselors. The ACA Code of Ethics is most recently written 2014. So we are due likely for an update, and there might be a few things that change. Now, because things change, I always, whenever I talk about ethics, I like to highlight some legislation that came out of Tennessee, and it's Tennessee Senate Bill 1556, House Bill 1840. What it does is it provides protections for counselors who would like to not provide services to a client because of a sincerely held religious belief on behalf of the counselor, as long as an appropriate referral is made. I always want to talk about this one because this is an example of the state of Tennessee government stepping into the professional board and making statements about what they can and cannot do. They went as far in the statement of the bill to say that because the ACA doesn't allow for counselors to refer clients based on a counselor's sincerely held religious belief, we are going to impose this legislation. It went on to refer to the American Counseling Association as a special interest group. This bothers me greatly. I'm licensed in the state of Tennessee, and it provides additional provisions where professional boards have to go through the Senate Committee on Government Operations to approve their code of conduct, their ethical codes. I don't know why a government agency needs to have oversight over what licensed master's level practitioners are doing, but this has happened. This bill was passed in 2016, and it remains there on the books. It has not been repealed. Why I bring this up every time I do ethics, even though it might be a little disjointed, not quite fit into the substance abuse, know what's going on in your states, know what's going on with the boards, understand how legislation and board behavior are going to have an overlap. And this is a really specific example of where they did and what it meant. Now, what this means for patients as well as practitioners in the state of Tennessee, that's debatable on terms of what if this actually had any core impact. But at the minimum, what it did is it told potential clients that they might have a door closed to them if and when they seek out services, if whatever it is about themselves does not align with that practitioner's religious beliefs. So that could be their own religion, their race, their sexual orientation, fill in the blank. Anything that might not connect with that practitioner might be grounds for not providing services. That's going to do a disservice. That's going to cause harm. We'll talk about the fun stuff for a second. I say that with a bit of sarcasm. The malpractice claims. So this is one study that's available. There's a few different bits of research out there. Some of these things can be hard to find in terms of national data, but for this one that's available is nearly 13% of malpractice claims against counselors involve breach of confidentiality. That will come up again as we continue to talk today. Of the 10,000 or so or almost 10,000 claims from this study, almost 7% of them resulted in that practitioner losing their license or they ended up forfeiting it. Now, rhetorical question, what do you think are some other common infractions? Think really quick. You might surprise you. That's right. Failure to meet CE requirements is the most common. I bet that wasn't the one you were thinking of. Now, that's based on this one study. It's several years old, but it did encompass about half the states in the union, almost 1,000 cases. 31% of them did involve continuing education. So the fact that you're here today, the fact that you're going to fill out a survey and tell us what you thought about this, you're completing your continuing education obligations, at least for 1.5 hours. Good for you. Dual relationships, next, unprofessional conduct, counseling without a proper license, or non-counseling related crimes, such as getting a DUI, can also result in malpractice claims. What are some common disciplinary actions? Depending on what it is, could result in fine, or you have to get some mandatory CEs, all the way to revocation and probation of the license itself. There's lots of information within each of our state guidelines and our board information about how reprimands are handled. And big one, get your CEs in. Here are some common tips to avoid malpractice. Excuse me, I went too far. So first of all, keep your professional boundaries in place. It is your obligation to uphold the boundaries, not the client's. Understand what your state standard of care is and stick to it. Know what the scope is, know what professionals with your license type are allowed to do. An interesting area where that comes up is, let's take the state of Tennessee, for example. Licensed counselors have two levels of an LPC. There's an LPC and there's an LPC MHSP. One allows you to provide supportive services. One of them allows you to do that as well as to diagnose. And there are differences, and you must operate with what your license allows you to do. Managing client expectations. We do that largely through our informed consent, but it's an ongoing process. We have to continually reinforce and possibly redirect expectations if they are starting to get out of line with what we're able to provide or with what is going to be attainable in the services that we are providing. Got to keep accurate and thorough notes. Consider your assessments, as whether you do with your agency or as a private practitioner. How do you know what it is that you are treating? Do you have a objective measurement tool? that is utilized. So some great examples of that. So as we think about substance use provider, there are several short form assessments that can screen for substance use severity, things like the audit, the CAGE, or many others. So you can easily plug those into the treatment that you're doing when somebody mentions that they might be using drugs or alcohol, and it might be becoming problematic. You can have something to start steering that treatment plan. Terminate a client who crosses your boundaries. Again, these are your boundaries, your responsibility to keep, and always knowing when to refer out, and especially when to recommend to a specialist. So if something is starting to get outside of the scope, or let's think about with substance abuse. If somebody is, they present to you and there's a problem, let's say with drinking, and then what ends up we find is that the drinking is maybe more severe than was initially presented. And maybe they're going to have some health consequences from it, like needing to go through detox to manage those withdrawals. Know when to get them in front of a facility or agency that can handle that in a medically safe manner. So for substance abuse treatment providers, all of the previous slide applies, but where we find many missteps among SUD providers is related to confidentiality, HIPAA and 42 CFR Part 2, not paying attention to professional boundaries, lots of reasons why that can happen, imposing of personal beliefs for those who are in recovery. Especially, there's a risk that can exist with that of overlaying personal experience and then bias as a result, and then also not knowing best how to resolve professional conflict issues that might come up, because substance abuse treatment can complicate some situations, which I'm going to talk about as we go. So let's begin with as we start looking at some dilemmas. Let's begin by looking at this one case. Donald, he's a licensed counselor. He has 10 years of clean time himself, and he actually sponsors several men from his home group. Now, if you don't know what that all means, good opportunity. That means we have a competency area that we might want to explore so that we understand the vernacular of recovery. So this counselor, he firmly believes in a total abstinence approach, which usually means absence of mind or mood altering substances in personal recovery. But the physician with the agency that he works with, he routinely prescribes medications to patients, specifically things like MAT, Suboxone, possibly methadone, and maybe things like tricyclic antidepressants. Now, one of his sponsees comes in for an appointment at the facility to seek medication. Now, there might be some ethical considerations to be considered here. Now, number one, Donald is going to have to reconcile exactly what his relationship is with this person who's come into the facility, because he has a sponsor or sponsee relationship with him outside of work. Now, he's also a licensed counselor at this facility where this client is potentially going to be giving services. He has to figure out how to reconcile how both could exist at the same time, but maybe they can't. And that's going to be something that he's going to have to figure out, and I would recommend that he seek some supervision, because he's dealing with two very confidential areas. The 12 steps of Alcoholics Anonymous, as well as the 12 traditions, speak to the anonymity of that program. So him talking about the fact that this is a sponsee of his would be inappropriate without the sponsee's prior knowledge and consent. Likewise, him taking information that he has gleaned at work and bringing it into that relationship could produce some problems. He's going to also have to reconcile what he thinks about medications and how they can fit into a recovery plan. He has the option of no longer providing sponsorship to this individual. That would be outside of his obligations as a counselor, because the other side of it is, if this person is seeking medication at this facility, he's not going to be able to withhold that simply because he happens to know that this person is in recovery themselves, because that's going to create is in this position complicated this situation. Now, this is a very common type situation. People who are in recovery who have prior relationships of some kind with a current or previous patient, those are all things that have to be reconciled within this individual, and also has potential ramifications for the organization itself. Now, one of the things with Donald was about his view about medication, which was solely a personal value, even moral idea that he had based on his experiences. We always have to remember that ethics are different from values and morals. Values are things that reflect our personal needs, our desires, what we want. And morals are statements that categorize ideas or actions, usually as an individual or as a society. We make distinctions between what is good and bad, what is right and wrong, what is sinful and righteous. All of those are dichotomies that exist, and those are values and moral statements that we make. And the thing that pretty much everybody has to reconcile in their life is that there's an ambiguity that exists between these two dichotomous ideas, that there is a little bit of the best and the worst of us, and a little bit of the worst and the best of us. And that's how everyone is. And when we can accept that, we tend to do a lot better. Now, we have to always remind ourselves, I hope, of the responsibility and to whom it lies. Our responsibility always lies with the client, with the patient solely. Now, things get complicated when we have all these secondary responsibilities, like responsibilities to member of the family that we're treating, if there's a family component to it. The agency to whom we are reporting can become a conflict at times if there are pressures of things like not discontinuing treatment in order to keep census high. Those can be conflicts that exist. We can come into conflict with a referring agency or individuals who might be sending clients our way. Think places like DHR, probation, relationships that we have with these community services. And what can happen is then, if the client is not wanting to collaborate with that referent, I should say, then we are at a stalemate. I'm not going to release any information if the client does not want me to. So I always then stick to, I can neither confirm nor deny, which can be very frustrating to a probation officer who knows that they have sent to you that individual in order for them to get into treatment, and the client has declined to sign that consent to release information. I have to uphold the client's wishes above all else. So we also have secondary responsibilities to society, the profession, and then also to myself. These are all things that I have to weigh. Now, how I have a responsibility to myself is with things like setting my own boundaries and my own self-care. And as many people in the profession know, we often sideline ourselves above others. We tend to not take our own advice, and we can overextend ourselves by trying to help. And the risk is we end up doing more harm than good if we end up getting burned out or suffering from compassion fatigue. I'm going to pivot a little bit when we talk about confidentiality. Very important concept, especially for substance abuse treatment providers. And we do know that most issues that arise in clinical practice come from issues of confidentiality. The principle being, though, that we respect the dignity and privacy, and therefore the worth of all of the individuals and those involved. It is our obligation to protect from unauthorized disclosures any of the information that we receive in the therapeutic environment. That is the base of the counseling relationship. We know that the people we serve have concerns about what they share with us. This is a much older study, 1999, but it talks about how fearful people are about leaks of information, to the extent where many people would provide incomplete information or not even seek out care, in this case of primary care at all, because they don't want their information recorded, because they don't trust what organizations and the government are going to do with that information. So those are the clients we serve who have a distrust many times of what's being shared. And that's why we have the regulations that we do in an effort to control some of that. Now, HIPAA and 42 CFR do a lot more than just that, but it does start that dialogue of I'm bound not only by my ethical codes of privacy and privileged information, but we have legal foundations that will keep your information confined to this to the services we're providing. I'm not going to spend a lot of time on HIPAA and 42 CFR. There's lots to learn about it. There's so many subsections of it. I'm just going to tell you in general what it is. I imagine most of you have some familiarity with it. So HIPAA being the Health Insurance Portability and Accountability Act. And what it does is it protects health information, especially as it gets distributed between health plans, clearinghouses, and other providers, so that there can be a streamlined golden thread of care. Because historically what would happen is we'd have these partitions be put up and people weren't able to communicate pertinent information when it was to the benefit of the client. But what it has to then do is it has to provide some minimum protections. And that applies however the information is disclosed, whether that's me telling it to you or providing you documentation in writing or giving you a copy of a medical record, something like that. It creates rights for the patient so that they can view their records, amend their records. Now, they can't destroy their records, but they can ask for things to be amended, or they can provide corrections if they choose. That is within their rights. And one of the big things that as this works with clearinghouses and employer-based insurance plans is it hopes to control some of the costs of treatment, because you have an added transparency of the types of services that are being provided among the clearinghouses and insurance coverages. Now, 42 CFR Part 2, I always kind of say is HIPAA on steroids, and it's not that far from it. This is going to apply for substance abuse treatment providers, which are called Part 2 treatment providers. That's what it's referring to. And it's specifically focused on those providers that do receive federally assisted government funds, but that has so many outreaching considerations. Any kind of Medicaid, Medicare, VA services, all of that is federally subsidized. So many people fall into this category, whether they realize it or not. Hopefully they do realize it, because what this does is it creates some additional constraints for anybody who's had identified issues with drugs and alcohol, a diagnosis, prognosis of that information. For alcohol and drug, as well as education programs, it creates additional stringent requirements for the individual. Now, there are opportunities for disclosing information. Now, most of them are going to come at the permission of the client, as in they sign a release that says you can send this specific information to this specific recipient for this specific reason. And there's lots of rules within HIPAA and 42 CFR about redisclosure statements and trying to control for information getting out to the wrong hands. Specific requirements on what has to be included in a HIPAA compliant entity, and protections that are put in place, that extend to things like telehealth and controlled management of an EMR. So many areas we could go down with that. But what I really want to focus on is how we disclose and what we disclose. So patient gives consent. That's one that's very clear, and they've given consent. They've assented to it. Good to go. Now, there are other limited exceptions for 42 CFR Part 2 where information can be disclosed and a release does not have to be present. I'm going to give you a few examples of those over the next couple slides. You also need to consider things like court orders, which are different from subpoenas. You need to remember that. Court orders, as well as duty to warn and duty to protect. We are going to talk a little bit about the duty to protect as it relates to child abuse as we go. But here are some other permitted disclosures. Medical emergency. If somebody is in my treatment facility and they're having a medical emergency, I can call 911 and I can get them help, and I can tell them the basic information they need to know. Like, what is this guy's age? What is his name? What is the next contact information for emergency referral? Is he on any medications that might be causing complications right now? Things to help keep the person alive are pertinent and fall under coverage. It's up to the provider to determine what a bona fide medical emergency is. But I always want to point that out because sometimes people get overly constricted when it comes to confidentiality. A medical emergency is going to supersede in terms of what I need to keep privileged. I need to do whatever I can to keep that person safe and well. Other considerations, crimes on premises. Now, that is one thing where a provider might take action against someone who has committed a crime. Many examples of what crimes that could be. Now, it doesn't necessarily work on the flip side where authorities might come into a facility or agency with an arrest warrant. That is not sufficient for me to violate someone's confidentiality. If I have authorities come into the facility, I do not have to tell them where that person is, especially if you're working in a private practice setting or private property type situation. There's lots of ways of handling that. That's not that all uncommon. There's things that can be done, and it tends to work out just fine. Internal communication, such as transitioning within one organization, within a treatment team. Very important to consider in general, who is part of your treatment team? Who really needs to know the information? Clinicians, doctors, nurses, they need to know, usually, depending on what it is. Your community representative, marketer, people like that, they don't really need to know. And so making distinctions that even though we're all part of one agency, there is still a need to know that exists that we have to be operating in. Now, other organizations for which we have a qualified service organization agreement, also known BAA, PSA, the people that we are basically contracting with for providing services, they have a need to know as well as the information for the benefit of the people that we are treating. Outside auditors, usually those in which we are contracted with, like the Joint Commission or CARF, whenever you are agreeing to be accredited by those organizations, there is a obligation that they have to come in and see what you're doing, and they have the ability to interview your clients and things like that. That's part of the deal. That's written into the agreements and how all that stuff works. Communications that don't disclose any patient identifying information, such as aggregate data, such as if Bradford was going to say, our success rate with people staying sober 5 years after they get treatment is X%. That didn't tell you anything. It's just based on numbers, based on a whole lot of people. And then also research. Not going to spend a lot of time on research. That's a very big topic. But if there was not going to be any identifying information, it was going to be randomized sampling, things like that. Now, there's still consents with the participant engaging in a research study, as it were. That can be kind of unwieldy to deal with, depending on what it is. And you also might have to go through the IRBs in order to get that approved, because it is human subjects after all. I'm not an expert on research. I can't tell you a whole lot more about that. Now, I want to pivot again, still talking about confidentiality a bit, but I want to talk about minors for a second. Now, this training doesn't really focus on the treatment of minors, but I've had a lot of experience working with those age 13 through 18. That's kind of where I started spending most of my primary treatment time early on in my career, and so it added extra considerations because upholding the confidentiality of the young person sometimes felt like a balancing act with also keeping parents informed and keeping other entities informed, usually things like DHR, probation, or schools even. So there was a consciousness of the need for minimal disclosures while also keeping people abreast of what was going on in treatment. And so very important to make a distinction with young people, really anybody, that there's a distinction between assent and consent. Now, when somebody signs a consent, a form, they're giving permission. And that's pretty readily defined. We know what that is. If you agree to this and you sign this, you're allowing me to do it. Now, assent is somebody agreeing to it. They're actually almost enthusiastic. Like, I think this is a good idea. I'm all for this. Let's carry forward with it. Because someone could sign a consent but not be very pleased about it. Such as what you might find with maybe young people. They might say, I'm willing to sign a consent for you to talk to my parents. I'm not really pleased about it. But that's where then figuring out that balance of, well, what is comfortable? What can we disclose? And in what form are we going to do that if a disclosure is going to be made? And being very forthright at the onset of treatment about, these are the things that I would need to involve your parents with, such as possibly drug use, if that's the prescription is being made. It could be things like risk-taking behavior or any potential dangerous situations that you as the provider might find the person getting themselves into that you're not able to reconcile with them. Now, there was a statement I read a long time ago, and I copied it here. It said, confidentiality exists for the benefit of the client, even if he or she is a minor. Now, I go one step beyond that. I say perhaps especially confidentiality exists for that minor, because we really must protect our minors, because many times working with a professional when they're in their early to mid-teens, that might be their first intersection of public health or community mental health or any other kind of treatment. And we don't want to create conflict to the point where they have a bad experience with their provider. We have a great opportunity for modeling professionalism and respect for them, to the point where they would be more likely to return to services when and if they ever need them in the future as adults. But that again can create some complications when you think about the rights of minors, which you'll have to really consult your state rules, because they vary widely on the age for which someone can consent for treatment, and even that type of treatment varies. Some states, substance abuse treatment is different from other mental health services or medical services, and ages can sometimes be aligned across those different categories, or they might vary by a couple of years in either direction. So a key kind of takeaway is that through laws, because things can be brought into court hearings, especially when you're working with a child and the parents are going through a divorce, or there's probation or DCS, DHR involved. I cannot 100% guarantee that everything that is in our therapy is going to be kept confidential. But it's my responsibility as an advocate to have discussions about productive exchanges of information versus counterproductive, and especially with the parents, of them understanding when they will be brought into the session if needed, or if not. So let's kind of bring that into a potential scenario where you have a 14-year-old female client. She tells you that she's snuck out of her house many times. When she does so, she has sex with partners who are a couple years older than her, while she's also engaging in drug and alcohol use. She tells you she has no intention in stopping any of this, and if you tell her parents, she will never come back to treatment. So, depending on kind of where your mind is at today, you different things of this might stick out to you. You might be focusing on the age of the individual. You might be focusing on the sexual contact and the potential risk for exploitation there based on this person's age, and that all we know is that other partners are a couple years older than her. Your mind might focus on the risk-taking behaviors, the sneaking out, and what potentially is going on there, and the risk that is being posed. Your mind might focus on the substance abuse, the fact that she tells you she's drinking and using drugs and the danger that that could pose for her. Then maybe your mind settles on that last statement of, what is the risk that now exists within our relationship, where we're basically being given an ultimatum by our client about how we're going to potentially involve other people. So let's think just initially about that sexual conduct or contact, I should say, and thinking about, if you were in that situation, in the pertinency of involving a parent when there's sexual activity by a 14-year-old. So this scenario was used in research study, and it asked a sampling of practitioners what they thought about it. And the results were that less than 25% of counselors they interviewed would breach confidentiality if they had a minor client stating that they were engaging in sexual intercourse. Now that number went down even more so by the time that the person was age 17 years old, to the point where only 7% would disclose that information. And about 11% of the practitioners in the survey say that they would violate the minor's confidentiality if directly asked to do so by the parents. This brings up questions about where we draw the line with ages and also possibly personal biases about behaviors of minor clients. Because we understand that there's a certain psychosexual development that young people go through, and sexual activity is not an abnormal behavior, but does this scenario in itself then create additional complications because of all of the constellation of issues that are going on? Lots to be considered with that. Now, regardless of where then we go, right? So, because we don't have a lot of time to really dig into each opportunity, whatever our decision is about what action we need to take about this, it is indicated that we review to the extent possible what is going to be disclosed to someone else if we found that to be necessary. If you thought that there was maybe a need to involve a parent, if that was going to be a good avenue to go down, if maybe you thought that this would require social services involvement, perhaps that would be something that you thought of as a solution to that scenario. Regardless, it's in the client's best interest, it's in our best interest to involve that young person in decision making beforehand about that information to be disclosed. What is it going to be? When is it going to be disclosed, and how? Perhaps even depending on the circumstances, giving them an opportunity to be a participant in that. And of course, that relies on a lot of weighing the pro and con of that for the development level of the young person, and many times their maturity level and their understanding of the situation. Because this can create a lot of complexity. There's lots of ethical issues that can arise from this, because we're trying on one hand to respect the client's privacy and confidentiality, but sometimes we find that there might be in the best interest in order to involve someone else in the care, whether that's a parent or another outside entity. But other things that can complicate that, things that might end up causing harm to that client, thinking about perhaps young people that you've worked with who have a history of working or have a history of untrustworthy adults in their life. Perhaps that's their parents, perhaps that's their healthcare providers themselves. And what is that going to create? And then there's also weighing the fear that can come from young people about the punishment, or even the shaming that can occur from parents or guardians who might be involved or informed about certain aspects of the individual. So when in doubt, we seek consultation. That's one of the benefits we have as providers of being able to reach out to like-minded colleagues and get some other information. I want to speak to a couple of these legal precedents that do exist. None of these are really specific to the counseling profession, but they create a legal precedent about different aspects with young people. This first one here, the right to privacy related to sexual activity by a minor, this all came about of a lawsuit in 2006 that involved the state of Kansas. In the state of Kansas, it was a requirement that any healthcare professional that became aware of a minor involved in sexual activity with anyone else, even another minor of the same age, it had to be reported. And so what happened was the American Psychiatric Association actually sued the state of Kansas and won. And the court decided that minors possess a constitutional right to privacy. Now, considering the age difference and risk of exploitation, that's another part of the story. But the basics is minors have a right to privacy. That's the takeaway. This other legal case here, Sterling versus Borough of Minersville. What happened here, it did not involve helpers, it involved police officers. Police came upon a parked car where two young men were engaged in drinking as well as sexual activity, and they were arrested for the underage drinking. While in the holding cell, the police officers were disrespectful, were just downright cruel to one of the boys, saying that we're going to tell your grandfather that you're gay, and well, in this young man's family system, that was not an acceptable sexual orientation. So prior to the court, he was released, and then prior to the police officer having an opportunity to tell the grandfather that his grandson was gay, this young man died by suicide. And so there was a lawsuit, and basically what came of it is that there is a intimate aspect of personality that is entitled to privacy protection under this law. So there is precedent that we keep information very much private. This very much reinforces that information is powerful. And if we disclose it under wrong circumstances, in this case, very wrong circumstances, it has impact on other people. Now, this Juan versus Wolf case, this was in a school setting, and what happened was the young person was out as gay at school, but was not out in their home life. And there was a disclosure made about the person's sexual orientation to the family that did not know that they were out. And so the case basically makes us consider that privacy, forfeiting privacy in one area, in one realm, does not forfeit in all contexts. So really, we have to always be mindful that someone might say something to us in a session. We cannot make the assumption that that information is known to all. And I can definitely see sexual orientation being one of those things that very easily could come out in a conversation, even if I was given consent to talk to a parent about therapy. If that young person hasn't made clear to me that they are not out to everyone, but they have come out to me, I have to do my due diligence to make sure that that is okay for discussion if it is pertinent. And of course, it would only come up if it was pertinent. Now, the big takeaway from it is circumscribed information, that we keep information that is relevant open for discussion. But if it's not relevant, we shouldn't be talking about it. And we even, with having a release of information, if we have that consent, the legal piece of paper, we still have protections that say we can hold stuff back. And that's what that 2001 case said. And there was also some recent legislation in the state of Alabama in March of last year, which this case here, the ex parte Emily E. Holt, you can look that up. You can Google that name. The case, it was two parents who were in divorce proceedings, and clinical records from therapy for a very young individual got subpoenaed. And the counselor attempted to quash the subpoena, as one would do. However, they denied it, and it went on to an appeals court at the state level. And they ended up reversing it and saying, no, there's no reason for this information to be involved in the court case. This information is privileged information, which historically had not been granted at that level of unanimous agreement to counselors. It usually was for psychologists, psychiatrists. So this was actually a pretty landmark decision, and gives more precedent to, I keep things private for the benefit of the client. Now, there are certainly mandated breaches of confidentiality, such as when a person is danger to self or others. There's legal precedent there through the Tarasoff case. I'm not going to go into detail about that, what that one is. I think most providers are very much aware of it. And we stick to our language of providing that duty to warn, duty to protect when we have that imminent danger to others. Child abuse is another one of those areas where we do have an obligation to breach that confidentiality for the benefit of the client, or the child. Could also be the client, could be the same. Every state tends to have different definitions of child abuse and neglect. These are the definitions within the state of Alabama. I've looked at many other states. There are obviously overlaps, but there are other exclusions even that give different language. So always check with your individual state as to what the law of the land is. Regardless, all states require mandated reporters to follow through with that report for the safety of the minor. There is no time limit on reporting. If the person is still a minor, we follow through with our report. If the person is no longer a minor, there's no need for a report unless there is reason to believe that another young person is being victimized, in which case we would move forward with our suspicion and follow through with the report. Every state has different ways on how you do it. In the state of Alabama, if you do a verbal report, you still end up having to do a written report, as an example. Other states differ. They differ also in what you have to tell them in terms of who you are and what your relationship is and all of that. Some states don't require any of that, but if you don't provide it, you give up your rights later on to know what the outcome of that investigation, if an investigation came to pass, you will not have any rights to it if you did not give that information on the front end. And then here are some of the other considerations. Now, thinking about drug and alcohol use, because this always is an intriguing area when thinking about child abuse. And there are different state standards that talk about what I have listed here. Some of them exclude a few of these, and then some add others. Now, an adult providing, either by selling or giving drugs or alcohol to a child, that is abuse. That should be reported. Manufacturing in the presence of a child, or having chemicals or equipment stored in the premises where a child resides, a lot of that legislature came out of the early 2000s during some of the bigger methamphetamine boom that we had. We still have lots of methamphetamine out there, especially in our rural communities. But in the early 2000s, if you recall, it was exponentially worse. It was where opiates are today. So a lot of laws of the land speak specifically to manufacture and chemical endangerment in this case. Now, using a controlled substance that impairs a caregiver's ability to adequately care for a child, that can become a real gray area among state laws, but also among decision making, because not every state clearly defines it, much like that. And then there can also be differences of interpretation with what that can mean. So that can be an area sometimes of debate. Now, exposing a child to criminal activity or distribution of drugs, what often comes with that is transient caregivers in the household, people who are coming in for buys, who are not members of family, or maybe who are, but people in and out a lot. There's usually firearms or possibly gang activity that go along with that. So many times that kind of gets into a constellation of other issues that are going on as well. Now, question that always then comes up is, well, what about expecting mothers? Is there an obligation to report to Child Protective Services if a client I'm serving is pregnant and is also engaging in drug and alcohol use. Well, depending on the state you live in, it's going to vary. In the state of Alabama, where I'm sitting right now, the statement from the Department of Human Resources says they do not take abuse and neglect reports on unborn children. That is their statement. Now, if I choose to call Alabama DHR with that information, they will provide me with information on community resources that may be of an assistance. Helpers will often then fall into another category other than people like nurses and doctors, because many times it's not until the delivery of a child that when they do the detection of presence of drugs or alcohol in the system, that then a report is made by another healthcare provider. That's usually how that ends up working. Now, states differ in this, in their interpretation of chemical endangerment and obligations to report. An example is the state of Arkansas, which has legislation on the books, something called Garrett's Law. What Garrett's Law does is it provides an opportunity for a provider to make a report, and what they do is they have very robust data about the individuals for whom they're opening a case. Now, these are not full cases. That's a distinction. These are it's kind of like they track them. And what they then do is they do investigations, and then they make a determination on possible removal of children. But in the majority of the cases, they are not removing the children, in about 85% of the cases year by year. Interestingly, marijuana is the most common substance that the expecting mother is using in the Garrett's Law data that is available. So there's lots of resources out there for mandated reporting. It is an ethical and legal obligation to follow through with our reporting. There can be a lot of fear that exists among practitioners to follow through with a report. This study I reference here said that 27% of patients drop out of treatment after their counselor broke confidentiality for the purpose of mandatory reporting. That number was a little bit high. I've seen other numbers as well that were lower. The takeaway from it, though, is people will respond better if there's a transparency about what has to be reported on the front end as well as through the process. Remember always that it is the obligation to do. Pivoting again, talk about confidentiality. I'm mindful of the time. I want to make sure we talk about a few more areas of interest. Competency. Competency is an ethical obligation. You have to be competent to do what you say you are doing in the helping of other people. Asking rhetorically, how do you know that you are competent to do something? What are the boundaries of your personal competency? That can be a very difficult self-assessment question that you have to give to yourself, and hopefully you can be honest with yourself, because there are very different standards among what an ability is or a skill. I have an ability to do this is not the same thing as a legal qualification that says you are a licensed provider of X service. You might be great at helping people, but until you have certifications, qualifications for it, you're operating without a net, basically. Training and certification goes to my ability and skill. I have a lot of interest in art therapy and utilizing art as a component in helping. However, unless I'm trained or certified in doing art therapy, I'm not doing art therapy. That is why we really have to make sure that people are getting the training that is going to be pertinent for the services that they're providing. Operating outside of your scope is where this risk falls. Continuing education is a never-ending process. I'm going to talk in just a second about some very specific continuing education items for substance use providers. Diagnosing versus assisting, I talked about that, a very specific Tennessee licensing issue that comes up, understanding the distinction between those two. And then impairment. We can't talk about work in substance abuse without talking about impairment. There's an ethical obligation about self-awareness of impairment that might cause harm to clients and avoiding that risk. But then the other side of it is an awareness we have of our colleagues in kind of stopping them at the pass if there's a risk of impairment harming clients, and either at first resolving it at the lowest level possible directly with that colleague. But if there is an imminent risk of harm or harm has already been done, taking that to the next level, which could include agencies, employers, review boards, etc. Substance abuse specific training, how do you know that the people that you're serving who might have substance use issues, they might be struggling with drug or alcohol problems, staying abreast of the latest research about drug and alcohol treatment, as well as just the drugs themselves. There's all kinds of changes in the field all the time. Kratom, bath salts, things like that, that just kind of jumped out in the last few years. Like, what are those? You might have a patient come in to your office presenting with other concerns, and they tell you that they're using this substance called kratom, and it's like, well, what is that? You have to do your own competency and get some information. Similarly, what are signs of intoxication or overdose for the various substances, so that because it might be hiding in plain sight whenever they come in for their therapy session about another issue. What are issues with overdose and ways that you can effectively reverse those? Great opportunity for all agencies, all providers to think about getting Narcan in their sites. It's easy to acquire, and it's worth its weight in gold if you ever have to use it. What are medications that are out there for the treatment of substance use disorders? How do co-occurring conditions impact the care of a substance abuse diagnosed patient, and vice versa? What are the risks that are inherent among those with substance use disorders? Are there other conditions that have parallels with drug and alcohol use, such as process addictions like food or sex addiction? Gambling, which is diagnosable, but the other ones aren't. And there's a great risk for cross addiction that happens in our work in substance use disorder treatment that we have to be mindful of. Just as we need to be mindful of family systems and how they're impacted by drug and alcohol use, and vice versa. And also recovery resources, understanding, being competent in what resources are out there: AA, NA, Smart Recovery, other community resources. What does it mean to have a sponsor, to be a sponsee? What are the 12 steps? How do they work? Why do they work? These are all things that, as you work with anybody, are likely gonna come up. If you work with anybody long enough, you're gonna work with somebody who's currently or historically struggling with drug and alcohol use. Moral character is part of competency with professionals, and it's one of those areas I talked about earlier that can lead to people losing their licenses if a board finds that somebody does not have quality moral character to be a professional. There's lots of examples out there of things completely outside of the practice that can cause someone to lose their license, like not paying child support, not paying taxes. Obviously, criminal convictions and failure to notify the board fall into that category, because every time you apply for a license or reapply to update your license, you have to attest that you have not had any criminal legal issues since the last time you applied. Similarly, you have to make an attestation about you're not under the influence of any drugs or alcohol that are impacting your care. So if and when that ever then came to light that someone was struggling with that as a provider, they would be at risk of losing their license. One of my last things I want to talk about, I'm just going to briefly go over it, is the dual relationships. This was the last topic I wanted to speak to. So dual relationships are a consideration no matter what area you're practicing in, whether it's drug and alcohol treatment or work with anybody. They're going to come up, and what is especially important for those who work with substance use disorders, and especially for those who may be in recovery themselves, is the overlap that can quickly start occurring, like that case example we gave earlier of that counselor, Donald, who he himself was in recovery and had a prior relationship with somebody who came into that treatment setting. That can happen and does happen. So reconciling what the code says versus what the code says plus what is going to be in the best interest of the client, because there are lots of examples of where a dual relationship can occur, and a dual relationship is basically just when we're wearing two hats, where we're a counselor and a fill in the blank, friend, family member, business partner, sexual partner, sponsor, sponsee. Now, depending on what the relationship dynamic is, there are prohibitions about it being acceptable. And then there are others where it's as long as it does not impact that therapeutic care, such as somebody being a distant family member, depending on the nature of that family relationship. Because you might have a family member you've never met, they're 5 times removed, fourth cousins, live 5 states away for your entire life. You might not know them from Adam. Does it cause an impact? You have to be transparent about it. You have to review the pros and cons. The client has to consent to it. Lots of considerations. Professional boundaries, there's a difference between a boundary crossing and a violation. So a boundary is a benign deviation from the standard, which is in itself not exploitative. Now, in the research, an example that is given is you're at your agency, the client's car dies, you give them a lift down the road to the Advanced Auto Parts. Is that in itself a boundary crossing? Sure, but did it exploit anybody? Did it take advantage of them? Did it cause any harm? No, not likely in that case. So is that something that you're willing to take on? Is that something the client's willing to take on? That was a very specific example. Not everybody would be comfortable with that. Your agency also might have policies in place about we don't transport patients in non-authorized vehicles, et cetera, and you'd have to comply with those as well. So there's lots of layers here when it comes to just a simple example like that that's given in the research. Now, violations, on the other hand, are harmful. They are exploitative. They are deviations. Remember always that setting boundaries is our responsibility. So take another example, real similar to our guy Donald earlier. This is John. He's also been in recovery for 5 years. He's now working as a counselor. He works at a residential treatment facility. He comes into work, finds out that one of his former using buddies has been assigned to his caseload. What is he to do? Well, the follow-up will vary very much. We need more information. How long, when was the last time that he saw him? When was the last time he used with him? Does he even know him, anymore? Is there even a relationship? Was there even a relationship at the time? Was it just somebody you came across in the throes of addiction? That's not necessarily a real relationship. Kind of best practices. If I was telling John, I'd say, talk to your supervisor, make sure this person, maybe gets reassigned to another caseload, because it's probably not going to be in your best interest. But the other thing that's going to come up is it's a residential facility. He's likely going to see you. You might be participating in the treatment team, even if you're not providing direct care to him. How are we going to reconcile that? What is the patient okay with? What are you okay with, John? And let's figure out how we can navigate through that. None of this in itself, though, is a deal breaker. We wouldn't say we can't treat this person because he happens to know John, and we can't say, well, we're going to have to put John on leave because he happens to know this person. This happens a lot. This is not an uncommon scenario. Violations, on the other hand, should be avoided at all costs. Things like accepting gifts can be a violation. I put a little asterisk there because considerations to be made about gifts, but certainly could be exploitative. Now, other much more clear exploitations, things like emotional involvement with a former client or current client, sexual involvement with a client or former client, and also providing treatment to a person for whom there was a previous romantic relationship. Other things that might be violations, like physical touch. We can often use touch, handshake, that in itself should not be itself a violation. Pat on the back, hug even. We have to be mindful of personal space, personal boundaries, and preferences, and our own personal motivations for why we're engaging in that haptic activity. Language can be a violation. 4-letter words using profanities. historically, in the history of substance abuse treatment, people have rationalized verbal abuse as confrontation. People using very explicit interventions and saying things like don't let the door hit you in the bleep on the way out, as a way of trying to jar that person into action when they are stuck in their denial. Well, I call that patient abuse. There should be no reason for that. That does not treat the person with dignity. Also, thinking about the terminology in drug and alcohol treatment itself, things like the word addict, and using words like clean and dirty to describe drug screens. Drug screens aren't clean and dirty. They're positive or negative for a substance. Clean and dirty has connotations about that person and can be very, very harmful. Also, self-disclosure could possibly be a violation depending on what it is and for what purpose it's disclosed. This brings up always then the person who's in recovery themselves. We have recovering practitioners. What do they choose to say about their own personal story, and to what benefit is it? Because it certainly can have negative impacts on people if it wasn't an appropriate disclosure, if it was maybe too personal. And always the rule with disclosures is it shouldn't be something that's going on right now. It should be something historical from which then the person can give perspective. We wouldn't disclose about what we're going through in the moment if it's a negative. Like if we're trying to normalize relationship problems, we wouldn't talk about the relationship problems we're having with our spouse or significant other that's ongoing. That would be inappropriate. That'd be too much focus on the practitioner themselves. Dual relationship considerations, if they're going to exist, you got to really play through exactly what that's going to look like and to whose benefit they are existing. Seek consultation, document it. If a dual relationship exists, really thinking about the power differential, difficult to change. Once we have changed the relationship that we have with somebody, you can't go back. Meaning that if you've ever provided treatment and then you happen to then years later end up having a different relationship with that person might end up needing therapy again in the future. Well, guess what? Now you have taken yourself out of the ability arena to be able to provide that services. Very last slide, then I'm going to be done. Decision making and ethics, continual process. Ethical standards are by no means a cookbook. They tell you sometimes what you need to be doing and be mindful of, but not necessarily how to do it. And every situation is unique. That's why we really have to have an understanding of all the principles, all the laws to be able to put the pieces together. Working in the substance abuse field adds a layer of complexity to a lot of situations. Many of them I've outlined for you today. Things like competency and dual relationships, as well as confidentiality, which has that extra layer to it. So always lots to be considered. And I have reached the end of my time.